Sir, just wait, sir. We are not ready.
नहीं हुआ है क्या? इसलिए एक्चुअली टाइम हो रहा है, एवरीबॉडी इज वेटिंग। ये लगाऊं क्या? इसमें नहीं चल। इसमें क्या प्रॉब्लम है?
Andrew, YouTube and recording has been started.
Okay.
Now I am giving broadcasting. Okay.
And go. We are starting. So should we start?
Andrew, you can start.
Sure, it's already 6. Let us start.
Andrew, let us start, sir. Yeah. Good evening, sir. Good evening. Good evening, all the professors, delegates, and participants, sir. And I welcome you to this today's session. And before I go ahead, let me mention a quotation, which is by a famous person, Mr. Henry Ford. As he has said that a business that makes nothing but money is a poor business. So by that, Wokhart believes in this philosophy, and that is why with this, Wokhart is associated with Orissa Journal of Orthopedics Association, Orthopedics and Trauma, which is we believe in knowledge. Knowledge begets business. And with this academic initiative, I welcome you to the webinar series 4. Today's topic is spinal tuberculosis. I will request all the participants to put your questions in the chat box or question answer section. As there is another thing to mention, God forbid, because the network is so poor, so it may happen that the network goes off. It will be a matter of 1 or 2 minutes. We are having a standby network, so we'll come back again. So please bear with us and stay with us. And let us go ahead, sir, with this. Let me mention that we have a platform called WorkMate. If there is any other queries beyond this webinar session, Seshindu sir, please next slide. Even beyond the webinar session, you have queries and you want to get it clarified. There is a platform called WorkMate at wokhart.com, where you can share all your queries in terms of medical, in terms of any formulations regarding any medications in therapy or anything, and it will be responded to within 72 hours. Next slide, please, sir. So with this, let me welcome and introduce Professor Dr. Nirmal Chandra Mahapatra, and he is a well-known figure now, and all of you are already familiar with sir. He is the editor-in-chief of Orissa Journal of Orthopedics and Trauma. And with this, I hand over the session to Nirmal sir. Nirmal sir, now please take over the session and Please come in.
Okay, thank you.
Sir, you can share your slides now, sir.
Well, good evening. I welcome you all to this seminar of on spinal tuberculosis. As you know, tuberculosis every year kills more people than COVID has killed so far. And also spinal tuberculosis is so rampant that they produce a lot of disability. And every postgraduate has to face a case of either spinal tuberculosis or paraplegia or trauma. Tuberculosis brings a lot of questions in the final examination. Since the exam, final PG exam is around the corner, so I expect that this seminar, this webinar will be very helpful for them. Okay, let me introduce you to our faculties and the panelists. So I have the proud privilege of welcoming Dr. Kiran Mukhopadhyay, Professor of Orthopedics in NRS Medical College and Hospital, Kolkata. As he is known, he is very well known to Odisha and he is very popularly known as Kiranda. He has a more than 25 years teaching experience with special interest in spinal trauma, deformity, and spinal infections. His basic research on spinal cord injury with Saha Institute of Nuclear Physics has been internationally acclaimed. He is also a guest lecturer of GIMA, and he has been a postgraduate medical examiner for a long time. You see, he's always affable and a jovial person with a smile, like Mona Lisa smile, you can call it. Now it's an honor to introduce my good friend, Dr. Alok Agrawal, who is professor of and head of the departments of orthopedics in Raipur, AIMS. All his degrees are self-explanatory, and it is very difficult to enumerate all his achievements. He is the editor of JOTR, CZIOA, CGIOA Journal. He is associate editor of IJOA, presented innumerable lectures and orations. He has won many fellowships, and I had the proud privilege of joining with him as a co-fellow, co-JJ fellow for 4 weeks all over India, learning with him for 4 weeks. And he's also our Odisha Orthopedic Association fellow. Now I'll introduce some of our people, faculties who will be presenting papers. They're just saying every father and teacher always wants that their offsprings and the students, they excel more than them. We have some of our presenter who are our students who has gone way ahead than us, okay? And they have made us proud. So I will introduce Dr. Bikram Kaur, who is now working as Associate Professor of Orthopedics in AIMS, who will be presenting on examination spine. He has a very interest in spine, and from the very beginning of his postgraduate career, and he's a EO spine fellow and also cervical spine fellow in Ross University of Chicago. Then Dr. Jitendra Kumar Rawat, and he is working as a consultant orthopedic and spine surgeon in Amri Hospital, Bhubaneswar. He has done fellowship in spine surgery, Gripmar, Delhi, and he has also done fellowship in spine deformity, University of Malaysia. He'll be speaking on epidemiology, etiology, and clinical diagnosis of the spine. Now I'll introduce my colleague, senior colleague, Dr. Madan Mohan Sahu, and he has more than 26-year teaching experience, and out of which 18 years dedicated to spine. In fact, he is the first spine surgeon, dedicated spine surgeon from Odisha. He is also a EO spine fellow in Royal Adelaide Hospital, Australia, WC Secret fellow in spine surgery, and he will be speaking on imaging modalities and laboratory investigation in spinal tuberculosis. Then I'll introduce Mantu Jain, who has always a great desire to learn almost all aspects of orthopedics, and he has specific interest in spine surgery. He's working as associate professor in AIMS Bhubaneswar. He has done spine fellowship in Kolkata and many certain spine fellowships in Spine Injury Center and also your spine fellowship. And he will be speaking on treatment of spinal tuberculosis. Now, Gurudev is a pole star among our spine surgeons in Odisha. He is the only person from Odisha who has done fellowship FNB in spine surgery, and he is working as assistant professor in orthopedics in AIMS Bhubaneswar, and he has done many fellowships, and he has done spine fellowship from Ganga Hospital, and he's also selected AO Spine Fellow for this year. Okay, he has many achievements, so we'll not waste time taking, and he'll be speaking on management of complications of TB spine, paraplegia, and kyphosis. I'll ask all the presenters to stick to their time of 10 to 12 minutes, not more than, keeping more time for a lively discussion, because we have a series of questions which we hope our postgraduates will be asking. So with this, I end my talk. I must introduce our Dr. Saswat Samant, who is a scientific coordinator and assistant editor of Odisha Journal of Orthopedics. Without his help, these seminars could not have been possible. He has been always behind and working hard to make this webinars a success. Thank you. Now I request Dr. Vikram to start his presentation.
Okay, good evening, sir. Thank you. My regards to my teachers, Nirmal sir, Madan sir, and my thanks to my colleagues. So I have to speak on clinical examination of spine with special reference to tuberculosis. Uh, so we will be discussing on broadly on these head history, general examination, inspection, palpation, movements, measurements, and neurology. Neurology is the most important aspect of clinical examination of the spine. So taking the history is always important in medical science, the age, sex, socioeconomic status. Am I audible, sir?
Yes, yes.
Answer. History is most important aspects of any examination in medical science. Age, sex, presenting illness, chief complaints, treatment history, personal history, all bears its importance. So let us take about the chief complaint in spine patients. In a pathology in spine, patient usually complains of either a pain or a swelling or some sort of weakness or numbness or deformity. These are the all complaints of in a spine patients. So pain, usually the pain, the site of occurrence, the mode of onset, the nature of the pain, and the radiation, whether it is restricted to the back or it's radiating to the leg, all these are important. It bears its importance. Then deformity, whether deformity is localized or it is deformity is gradually progressing or it is static deformity. The swelling is where is the swelling, how it onset, what is its how it is onset, then when it is first noticed, duration of the swelling and progression of the swelling, stiffness, weakness is unilateral or bilateral, whether it is involved the both motor and sensory, or the duration of the weakness, it is progressing or it is involving to the bladder and bowel. All things bear its importance. Then ask for any history of trauma, any constitutional symptoms, any history of hemoptysis, because we are dealing with the tuberculosis. We must not neglect taking the history. We must not, we should ensure that we are taking any history of pulmonary symptoms, all the respiratory symptoms, any pelvic inflammatory disease, treatment history, immunization history. These things are important taking the, while you are taking in history. The past history you have to take whether patient is in immunocompromised host or any patient is suffering from any malignancy or he has suffered from tuberculosis beforehand. So personal history, whether he is a smoker or is a alcoholic or he is having addicted to any drugs. Menstrual history you might take in female, but it is not so important in tuberculosis. Family history is important, whether he has been exposed to any patients suffering from tuberculosis in his family. So before examination, coming to the examination proper, before examination, it is important for the postgraduate students who are exam going to keep in mind it properly. Introduce yourself to the patient, ask for the permission for the examination, explain the patient properly, and patient must be exposed appropriately. Appropriate exposure should be done, and tell the patient what you are going to do, and if any harm occur, then he or she should tell you. If the patient is a female, take a female attendant or a nurse with you. So general examination, head to toe examination, see for any neurocutaneous marker or hairy patches. General examination also includes pallor, sadness, clubbing, lymphadenopathy. Lymphadenopathy bears some importance in tuberculosis. Then inspection, you have to see the gait and attitude. Gait in a tuberculosis is known as Alderman's gait. It's a stiff spine gait with a chest protruded outwards. So attitude of the spine in a painful inflammatory condition of the cervical spine, patient holds the neck like this. This is the cervical spine, port spine in the cervical area. In a tripod sign, patient may also attend in a tripod sign in case of a dorsal lumbar tuberculosis to avoid weight bearing through the dorsal lumbar area. Inspection from the back, see the level of the shoulder, see the level of the scapula, see the level of the highest point of iliac crest. Then swelling, this we have to keep in mind what are the possible area of cold abscess where you should see the swelling, the neck, petit triangle. Whenever you are describing a swelling, the size, shape, redness, skin changes, all should be noted. So these are the sites of psoas abscess. Many examiners have a fun of asking what is the boundary of the petit triangle. One should remember that. Then scar, sinus, central furrow, if it is obliterated in case of a atrophy of the muscles. When it is muscle spasm, the central furrow is prominent. So this is the central furrow is obliterated and central furrow is prominent. So inspection from the side, you have to comment on the lordosis or kyphosis. Kyphosis may be a knuckle when it is one vertebra involved. Angular or gibbous kyphosis, it is involves around 2 to 3 vertebra. If it is more than 3 vertebra, then it is called a round kyphosis. So these are the 3 types of kyphosis you must note. Then inspection from the front, prominence of the chest, if there is malnutrition or previously geriatric features, pectus carinatum may be there, or in case of scoliotic spine, there may be upgoing of the pelvis. Then you must palpation. In palpation, comment on the local temperature, tenderness. Then the tenderness may be directly on the posterior elements, or maybe it may be a rotatory tenderness, or it may be thirst tenderness. Thirst tenderness and rotatory tenderness present when the lesion is on the anterior aspect of the spine. Then Kibler's test, you must, when the skin when the skin is pinched over the paraspinal area, if there is paraspinal tightness, skin cannot be pinched. Then the movements or special test. Movements or special test is in cervical spine. If the patient can move without any pain, ask for movements. Otherwise, don't do any forceful movement in case of tuberculosis of spine or any spinal disorder except scoliosis-like movements. So normal range of movement we must know before going for the examination. These are the movements of the cervical spine. And in dorsolumbar spine, the auto test mark a vertebra over the C7 prominence, 30 centimeter below that area, and you measure in both inflection and extension. Then the modified Scoville test, everybody knows that in case of ankylosing spondylitis, any DGS you may measure this by modified scoreboard test to assess the movement of the dorsal spine. Extension, this is the lateral flexion. Lateral flexion, normally patient can go up to the lower third of the leg in lateral flexion. Then the rotational movement, you may ask for the rotation of the spine. Then special test, straight leg rising test, femoral stress test, bow string test. These are usually important in case of prolapsed intervertebral disc, not very important in case of tuberculosis of the spine. Then sacroiliac joint examination you must do, because sacroiliac joint tuberculosis may be an associated finding. The Janssen test, Gillis test, you must know how to do it, and you must demonstrate before the examiner. Janssen test and Gillis test. Then most important is coming to the examination of the nervous system. The postgraduate students who are examining going candidates, they must practice it. I would like to suggest they must practice it before going to the practical examination. So the heading of clinical nervous system examination is assess the higher function test and cranial nerves. These are not very important in orthopedics, but we have to ensure ourselves that the cranial nerves and higher mental function are intact. Otherwise, we cannot proceed for the motor system or sensory system examination. Then motor, sensory and bladder power system. Coming to the motor system examination, see for the bulk of the muscle, tone, reflex, power, coordination of the movement and involuntary movements. Always measure the see, palpate and measure in when you are commenting on the bulk of the muscle. Take a fixed bony point, from a fixed bony point equidistance, either thigh or leg. You have to measure the girth of the limb to comment on whether it is atrophied or hypertrophied or something like that. So this is the tone of the muscle. What is tone? Tone is the definition of tone is it is the resistance to the passive movement. Tone may be hypertonia or atonia. Hypotonia or hypertonia. Plasticity or hypotonia occurs in lower motor neuron type of palsy, and spastic or hypertonia occurs in upper motor neuron type of palsy. We usually encounter the upper motor neuron paralysis in tuberculosis, where you get a clasp knife type of rigidity. Then come to the strength or power. Strength of the power, according to the MRC grading, Medical Research Counseling, you all know the grade of muscle power, 0 to 5. 5 is the normal power, 0 is the no muscle power. That you must mug up before going to the examination. Then you must know what is the route involved for all joint movements. Shoulder abduction, elbow flexion, wrist flexion, extension, grip movement, then fanning of the fingers, then hip flexion, knee flexion, extension, ankle dorsiflexion, or root value. All root value you must know before examining the patient. Then in case of spasticity, it's difficult to grade the power accurately. Then reflex. Deep tendon reflex are elicited by stimulating a stretched tendon. These are monosynaptic stretch reflex. Reflex are also grading from 0 to 4. 4 is clonus, 0 is absent, 1 is like an ankle jerk, 2 is like a knee jerk, 3 is brisk. So you have to grade the reflex also. You have to know what is the method, where you should stand, how to stroke the tendon, where to keep the your finger. That thing you must practice before going to the clinical examination. Bicep reflex, supinator brachioradialis reflex, tricep reflex, then knee jerk, then ankle jerk. You have to elicit before the examination, because usually examiners want to see how you are examining. That is very important. And they usually ask what is the root value and what is the inference of this reflex. The ankle clonus, see how the doctor is holding the limb. You have to hold like this, ankle clonus or patellar clonus. Then if patient is very conscious, you can do some reinforcement by Chandraski maneuver or clenching of the teeth. Then superficial reflex or polysynaptic reflex initiated by stroking over the skin. These are the plantar reflex. Plantar reflex, if the plantar reflex is Babinski positive in upper motor neuron type of palsy, this is the plantar reflex. You should know where to start the stroking and where to end. What is the inference? What is the positive sign? What is the negative sign? This is time constraint. I cannot describe details of this, but you must know which is what. Abdominal reflex, which involves D7 to D12 segment. So it may be absent in very aged and obese person with scar. There may be some abdominal scar, it may be absent. So that is the thing. Then anal reflex, bulbocavernosus reflex, and cremastoid reflex you must know. Many examiners ask it. So you have to do a PR, insert your finger inside the anus, do a bulbocavernous reflex in male and female. Both you should know how to do it. What is the root value? And what is the cremastoid reflex, what is the root value, how to do it, you must know before going to the examination. Then the coordination of the movement. Coordination of the movement, these are very important in case of cerebellar disorders. Involuntary movements and coordination of the movements are usually found in case of cerebellar disorders. Then come to the sensory system. You must know the dermatomal distribution of all nerves, starting from C2 in head to L5 at the foot. Dermatomal distribution, you must ensure that yourself that you are having cotton pin thermal assessment for cold and warm water. All these things you must be having before going to the examination. Then modality of sensations, these are theoretical aspects. Then pain, don't do an hypodermic needle, take a pin, just alpin, and ask whether she is able to appreciate it or not. Then temperature, I told you, warm water or cold water you have to take, that is the thing. Touch, take a piece of cotton and ask it whether she is able to appreciate it or not. Joint position, how to do the joint position, ask the patient, explain the patient what you are going to do and ask this. This joint position, proprioception, stereognosis. Stereognosis means to identify a known object, position of this, position sense, vibrations, all are posture modality, posture column sensations that you must know. Then autonomic system. Bladder and bowel functions are very important in case of tuberculosis of spine. Bladder in nerve cell if it is an upper motor neuron type of palsy, it is a automatic bladder or a spastic bladder. Usually the lesion is more than the 11, and it is a lower motor neuron type of palsy. It is a flaccid bladder where there is an autonomous bladder where there is failure to empty. Their bladder will be distended and suddenly it gives you. That you should keep in mind. This is a very essential thing to remember, that what is a spastic bladder, autonomic bladder, automatic bladder, or it is a lower motor neuron type of bladder, that is a autonomous bladder. So comment on the bed sore, because many tuberculosis pod spine patient is having bed sore because of prolonged bedridden due to paraplegia. You have to know which is what, grade 1, grade 2, grade 3, grade 4. Grade 4 is where the bone is involved in case of a bed sore. That you must specify what is the type, which stage the bed sore is. Then most important thing is integrating the spinal vertebral level. This is the chart where the cervical spine you add 1, thoracic 2, 7 to 9 is add 3. This is the chart you must know before assessing what is the spinal level. Because we have to, the main purpose is we have to know what is the site of the lesion, what is the spinal level, whether it is extramedullary or intramedullary, what is the extent of lesion, and the provisional diagnosis depends upon that thing. So the difference between upper motor neuron and lower motor neuron is The reflex, are is hyperreflexia, is hyporeflexia, decreased tone. The superficial reflex are usually absent in upper motor neuron type of lesion, and muscle with the fasciculations, the involuntary movements are present in lower motor neuron types of lesion. Extramedullary, intramedullary difference you must know also. The radicular pains and vertebral pain are common in extradural pathology, and it is unusual in intramedullary pathology. Trophic changes are more common in intramedullary pathology, and it descends downward. Gradually, it descends downward in case of intramedullary pathology. So, extent of deficit, Goels and Kumars have graded the extent of paraplegia is stage 1 to 4. 4 is there is flexor spasm, bladder bowel involvement, more than 50% involvement of the sensory system. In stage 1, if patient is unaware of deficit, you have to elicit the neurological deficit. Mild and moderate are in between. You have to say the extent of the deficit. So, the final diagnosis include your site of the lesion on the vertebral column, which spinal level it corresponds to, and what is the pathology, whether it is an intradural or an extradural pathology, and most likely to etiology you have to say, so that you can give your provisional diagnosis. So, for example, this is an extradural compressive myelopathy, grade 4 paraplegia of Tully classification. Vertebral level is D5 to D6, dermatome level is D7. Most probably the etiology is tuberculosis of spine, D5, D6. This should be the provisional diagnosis before you comment on the investigation process. So that is the aim of the examination. So,
well, we'll keep the questions to the last. There are many questions for you, Vikram, and you have a MCQ. You can do that now. But after we complete all the lectures,
okay,
we'll be having all the question answers.
Sir, there are some questions I have put. The Miller asthma for postgraduates, they may find the
let them answer that. In the meantime, I'll ask the panelists to give their opinion, expert opinion on the clinical examination.
Okay.
First, Dr. Kiran Mukhopadhyay and then Alok. I request the panelists to give their expert opinion how to approach a spinal case as per the Vikram's lecture. Kiranda.
So thank you, Dr. Vikram. It's a very useful presentation by you. You have almost covered all the things. But video demonstration would be if there is video demonstration of the reflexes, so that would be a better option. But there is time constraint, I know, and I think you have covered everything very well. And there are a few questions. I think the question answer will be very interesting. The questions we will take, I think, after the end of this, all the lectures, I think. So it's a very useful lecture given by Dr. Vikram. Thank you.
Thank you, sir.
Dr. Alok, anything you want to add to the lecture?
See, one thing which is in the mind of the students is the patient is having a damaged spine when they are examining. It is not a case of low back pain. So in those times, should we go for a complete examination or not? So one thing is definitely there. If you are having a paraplegic patient or patient with neurological deficit, or is having a port spine which you knew previously also, then avoid doing movements, avoid damaging the patient, and the examiner will let you do all those things. It has been a very good presentation by Dr. Vikram, and I have to appreciate it. But one thing is definitely there, that while doing our examination, we should not be able to damage further the patient's disease spine. Second thing, we have to take care that we do our marking so that it is clear that we know at what level corresponding to what levels, and where lies the abscess and where is the wasting. So if you have done this marking in the start only, questions by the examiner will become less and less. Thank you.
In case in the examination, it's often the question is asked, and that is the one point should be emphasized during this lecture. That is what is log roll technique, and this is usually we get tuberculosis patients. So to prevent further damage, we must know the log roll technique, and we often ask in the examination the examiner to examine from the back, and if he does not ask for assistance for the log roll technique, then it's a very crucial point. So lockdown technique we should emphasize a little bit more, and asking the student that you must know lockdown technique, and if you are asked to examine from back, or then you have to, if you have to turn the patient, you must ask for the assistance and do a proper lockdown technique.
Well,
One
Dr.
common
Alok,
thing,
if I may ask, if you mark this by markers in the back, don't you think some people may object, and most of the students, after they complete the exam, they go away and without erasing all those markers, and somebody may complain. Does not it creates rights issue?
so that is the important thing, that we should carry skin marking pencils. The mark of those eosin and hemotoxin goes away very easily. It doesn't damage the skin. That is one thing. One thing more which I wanted to emphasize was that when you are asked to demonstrate spinal tenderness, so that is important. Some people start going to thumping, that will be damaging the spine further. So
Yes, yes.
going in that way, that you demonstrate spinal tenderness by putting a rotator pressure on the spinous process or on the sides, that is very important instead of damaging the spine further.
Well, I'll request all the participants to SMS or send their questions. So we are collecting, we'll have enough time. If possible, we'll extend the time till 8 p.m. and so that we'll clarify all your doubts. So keep all the questions. Now I request Vikram, if your MCQ is over, I will ask the next speaker
Yes, sir.
to.
MCQ is over, sir. You may
Uh-huh.
skip to the next speaker.
I
So
feel
you
he should tell the
explain.
answers also, that will be good.
Yes, yes.
Yeah, we'll give answer in the last while
Okay,
we'll be
fine.
discussing.
Thank you.
Now I request
Good, Vikram.
Dr. Jitendra to speak on the etiology and epidemiology. Jitendra?
Nirmal sir, when you want to launch the poll, you just inform me.
When?
When you launch the poll, there is some question answer is there in the polls.
That he started now, na? In between, you can
No.
send as a questionnaire to all the participants. They will
No,
answer back.
There
You
is
should have a live chat.
there is some polls is there where student can directly answer over here and you can see it.
I think every student has some queries, and if you answer in general, then everybody will learn from that. So I want that we should concise. After we complete the presentation, we'll have enough time for discussion. All the questions we said that we'll be asking to panelists and other faculties also, so that everything will be clear. If possible, we'll go up to 8. No problem. Jitendra, carry on.
सुनाई दे रहा है?
Respected teachers, I will be speaking about epidemiology, etiology, and clinical features of spinal tuberculosis. So, as all of you know, spine is one of the oldest recognized disease of human history. Dates back to Rig Veda and Atharva Veda time, but it is the 9th leading cause of the death worldwide, and every year 15 lakh people die due to tuberculosis, and around 1 crore cases detected each year worldwide. So among this 1 crore, around 4.8 lakh cases, they are resistant to rifampicin. And in India, the incidence of MDR TB is, ranges from 1.1% to 24%. So globally, the incidence of TB is decreasing at the rate of 2% per year, and there is a target by WHO to end the TB epidemic by 2030, and India, the target is around 2025. So though it is prevalent in worldwide, but 2/3 of the cases seen only in 8 countries. Am I audible?
Sir, you are audible.
Though it is prevalent in worldwide, so 2/3 of the cases seen only in 8 countries of the world. And among this, India is the leading country, followed by China, Indonesia, Pakistan, and Bangladesh. And 1/5 of the total case of the world are seen in India only. The tuberculosis, there are mainly 2 types. It's a pulmonary and extrapulmonary. Pulmonary is the major, that is 75%, and the extrapulmonary TB is only 18%. So extrapulmonary TBs are the lymphatics, pleural, musculoskeletal, meningeal, and genitourinary. So among all the extrapulmonary TB, the musculoskeletal TB comprises only 11%. And from this musculoskeletal tuberculosis, spine comprises the 50% of the TB. It is caused by the Mycobacterium tuberculosis, rod-shaped gram-positive acid-fast bacilli, aerobic, non-sparing, but it can produce biofilm, so it can get adhesion to the metallic implants. So in active tuberculosis, there is no fear of using implants. Once the organism enters into the body, it is surrounded by the mononuclear macrophages, and it was phagocytosed and degraded by the lysozyme enzymes, and the byproducts of the degradation, that is the lipid byproducts, induce the cell to convert into epithelioid cell, and the protein byproducts cause the protein denaturation, causing the caseous necrosis, and which stimulates the epithelioid cells to merge with each other and form Langerhans cells. And this is the pathognomonic of the tuberculosis. So, but some microbacterium escape from the from the phagolysosome into the cytoplasm of the macrophage, and they stay alive for a long time as a latent. And when these macrophages enter into the bloodstream, they spread the disease to different parts of the body. So only 15% of the infected patients develop active disease. It may be due to some people with this condition, they are more prone for this infection, like malnutrition, diabetes, dialysis, patients with immunodeficiencies, and with repeated pregnancies. So the TB spine is mainly secondary to an active extraspinal lesion. The bacteria enter straight to the spine through the prevertebral plexus, which is formed by the anterior and posterior spinal artery and radicular vessels. So the bacilli reach the subchondral area of the vertebra by the segmental artery, and there is involvement of the paradiscal region of the adjacent vertebra with its common blood supply. And the disc space narrowing in a TB is secondary to the disc degeneration due to the loss of the nutrition from the end plate to the disc. So subsequently, there is destruction due to the lytic destruction due to and osteoporosis, and there is a pathological fracture and collapse of the vertebra similar to the metastatic vertebra and osteoporotic fracture. And this fracture and collapse leads to deformity of the spine, leading to compression of the spinal cord. And over the time, this spine will heal, but the deformity will remain. And in a prolonged, if the deformity will be prolonged, then there will be neurological deficit. The deficit can be, as described previously by Dr. Vikramkar, that can be knuckle type, angular type, or a round kyphotic deformity, depending on the number of vertebrae involved. So there are 6 types of involvement of the vertebra. The most common is paradiscal, when the bacteria lodges at the disc, at the site of the disc, and it is mainly spread through the artery. And the second is the central type, the bacteria lodges at the most cancellous part of the vertebral body, that is the central. Then when the disease starts just beneath the anterior longitudinal ligament of the spine, it is called anterior, and there is collection of the pus, and the pus spreads subperiosteal up and down, and there is subperiosteal stripping leading to the necrosis of the vertebral body. And the appendiculars are the involvement of the posterior elements, transverse process, and the facets. And there is a variety when there is no involvement of the vertebra at all. There is only extensive scald abscess, that is called non-osseous variety. And there is a type where there is a complex variety where is multiple level of involvement with skip lesions. The origin of the disease is not known, so it can be classified as indeterminate. Coming to the clinical feature, it usually occurs in 3rd decade of the life. The male-female ratio is equal. And there is 2 stages of the tuberculosis. One is active stage, Another is healed stage. In active stage of the tuberculosis, there is constitutional symptoms like loss of weight, appetite, malaise, and in specific symptoms for spinal tuberculosis are night crash, stiffness of the spine, deformity, lymphadenopathy, cold abscess, and neurological deficit. In healed stage, all the constitutional symptoms they will recover, like there will be weight gain and increase of appetite. But the specific symptoms like neurodeficit, deformity, and stiffness they will persist. So the neurological deficit stage into four types according to the severity of the disease. In the stage one, the patient is not aware about the deficit, and the weakness or deficit is detected by the physician. In stage two, though patient is aware about the deficit, but he is able to walk with a support. Stage three is not ambulatory, not able to walk, and there is spastic paralysis and sensory deficit less than 50%. And in stage four, there is flaccid paralysis, sensory deficit more than 50%, and there is involvement of bladder and bowel. So the paraplegia in tuberculosis can be classified into early onset paraplegia and late onset paraplegia. Early onset paraplegia is a progressive paraplegia, develops during the active phase in the first 2 years of life disease. And the inflammatory edema is the main underlying pathology, and it is a good prognosis. And late onset paraplegia mainly occurs after 2 years and due to mechanical pressure, and it is prognosis is bad. So the factors responsible for neurological deficit in the TB spine can be classified mainly into extrinsic factor and intrinsic factor. And the extrinsic factors in active disease are inflammatory edema, abscess, sequestrated disc or bone, and pathological subluxation. And the extrinsic factor in healed disease are internal givers, dural fibrosis or cicatrization, sequestrum of the body, canal stenosis, and debrima, TB debrima. And the intrinsic factors are prolonged stretching of the cord over the deformity, tuberculosis meningitis, infective thrombosis or endarteritis, syringomyelic changes. So the cold abscess are formed by the collection of the product of the liquefaction, and it's composed of serum, leukocytes, caseous material, and bone debris. They tracks away along the different muscle planes and neurovascular planes, and sometimes they burst in and reach the surface, and sometimes they burst to form a sinus. So the location of the cervical the cold abscess are retropharyngeal. This can lead to dyspnea, dysphagia, hoarseness of voice. Posterior border of sternum mustard, it can go up to back of the neck to the nerves, and it can also go to the axilla. In lumbar spine, it can present as a psoas abscess with pseudoflexion deformity of the hip. It can go up to the medial aspect of the thigh beneath the inguinal ligament, and it can be present in this petit triangle. In the thoracic spine, it can go along the nerve roots up to the anterior chest wall, lateral chest wall. So coming to the differential diagnosis of tuberculosis, it can be pyogenic spondylitis, brucellosis spondylitis, or metastatic spinal disease. So the pyogenic spondylitis is mainly it's the acute condition, and the tuberculosis and brucella it's more a subacute to chronic, and the metastatic is also acute condition. And the pyogenic mainly in children and young adults, and the tuberculosis at any age, and the metastatic in the middle and mainly in the elderly. In tuberculosis, there will be a lot of cold abscess, but in pyogenic, there is minimal soft tissue involvement. And in metastatic, there is involvement of the mainly posterior elements like lamina, posterior part of the body. Here you will get a history of you may get a history of exposure to tuberculosis infection. In pyogenic, there may be history of diabetes mellitus, and brucella there may be history of ingestion of pasteurized milk, and definite in metastatic, and there will be a systemic malignancy history, and it is more common in thoracic spine, metastatic, and tuberculosis in thoracolumbar area. And you can get constitutional symptoms in tuberculosis, but you may not get a constitutional symptom here, but you can get a high fever with seal and rigor. And in this metastatic, you can there will be radicular pain, which may be absent here. So these are the differential diagnosis. Thank you. So I don't have any MCQs. I have not prepared any MCQs. Hello.
Well,
Hello.
thank you, Jitendra, for such a nice lecture within certain time. Now, I will ask all the panelists to give a few comment on how the examiners what expect from this lecture. I mean, by early and late onset tuberculosis, which is commonly asked by the examiners. What is their take on these 2 points? But all the questions we'll discuss in the last, because there are a lot of questions people have asked. Okay. Kiran sir and then Alok. Your expert comment on this early, late onset and how differential diagnosis.
Yeah. Dr. Jitendra has already said the early onset and late onset paraplegia, and these causes in the examination. And another is regarding the differentiation between tuberculosis and pyogenic. In fact, regarding these differences between tuberculosis, there is not much difference, but the main difference nowadays is by MRI. So that can be asked, what is the differentiating point in MRI in case of tuberculosis spondylitis and pyogenic spondylitis.
Alok.
He gave a very detailed thing, but definitely what he has told, I'll just repeat it, that we should be knowing from where the tuberculosis spine start. That is very good. We should be knowing the pathology, how the pathology is coming. We should be knowing where the abscesses is trickling down, and we should be knowing the classification: normal, mild, moderate, severe. Dr. Kumar and Goel's classification, which is told, was excellent, and that is what we expect at all the times. So that is good, and we'll discuss it further later on. Thank you.
Okay, thank you. Now I will request Madan sir to start his talk. And all the participants to send their questions. Yes, sir. Madan sir, please share your screen.
Is it coming?
Yes, yes.
Hello.
Yes, sir.
Yes, it's coming.
Yes, sir. It is visible. Sir, please take it to the full screen, sir.
Okay. Okay.
Not that one. Here.
Below, sir. Below.
Below.
There is a cup like, yes.
Yeah.
Please click it.
Yeah. So I will be talking laboratory investigations in the tuberculosis spine. So straight away, Vikram has, Jitendra has already talked about everything, most of the things pathophysiology, and I will be coming to straight away to radiology of the spine, because this is the basic investigation we do in most of the spinal tuberculosis. But the irony is it is only 15% sensitive and takes at least 3 weeks to show up the spines. In the early stage, you may get a vertebral osteoporosis, narrowing of the joint space, indistinct paradiscal vertebral margins, and paravertebral soft tissue setup. And in late stage, there will be destruction of the vertebral bodies, increased paravertebral soft tissue shadows, and sometimes you may get lateral translation and dislocations, and there will be decreased lordosis and increased kyphosis in late stages. This is a central type of lesion what Jitendra told in pathophysiology. course, this is not an X-ray, this is an MRI. The vertebral collapse produces vertebra plana-like appearance, and X-ray or imaging collapsed vertebra, and usually there is a disc space preservation. In anterior type of lesions, usually the pus spreads over multiple vertebral segments, stripping periosteum anterior to the vertebral bodies. Both pressure and ischemia combine to produce anterior scalloping, which is known as aneurysmal sign. Aneurysmal sign because it is mainly seen in the abdominal aorta aneurysm, producing this type of lesion. Collapse of vertebral body and diminution of the disc space is usually minimal and occurs late. Usually we ignore chest X-rays, but 66% of these patients will have an abnormal chest X-ray. So they should be ordered for any osteoarticular tuberculosis. These are some of the pictures of the paravertebral abscess, uniform type, tense abscess, and there is also abscess shadow in the anterior to the cervical spine pathology. This is an X-ray of risk factors in children tuberculosis, described by Rajashekaran. Type A is a subluxation of the, type A is type B is retropulsion of the vertebral bodies, type C is a lateral translation, and type D is a toppling of one vertebra over the other. If two of the signs are present, then there is chance of severe kyphosis and neurological deficits. And this is a measurement method of angle of kyphosis. And these pictures are all self-explanatory. There are two methods. This is one method A, and this is another method C. This is the Cobb's method, similar to the method we use in scoliosis angle measurement. And come to this CT scan in spinal tuberculosis, which is also very useful. It will show extent of bony destruction. It can show early identification of the posterior element. And you can also plan your percutaneous biopsy accordingly. And it is also useful in detecting lesions in CV junction, cervicothoracic, and sacroiliac joint areas, where conventional X-ray will not be very much useful. And types of destruction can be known. Presence of, lastly, the presence of calcifications, if it is seen within tubercular abscess, is a pathognomonic sign of spinal tuberculosis. There are various types of CT scan lesions, fragmentary, osteolytic, and soft periosteal and sclerotic varieties. MRI is told to be the gold standard radiological investigation. It is 90% specific. Early you can diagnose, skip lesions can be visualized, and in the CSF is usually seen hypointense on T1 image and hyperintense on T2 image. And presence of a septate prevertebral, paravertebral, or intraosseous smooth walled abscess with a subligamentous extension is very characteristic of tubercular abscess in the MRI. These two pictures are all T2 images where the CSF is white, is hyperintense. This is a gadolinium contrast image we do to differentiate it from the pyogenic infection. This top picture A is a pre-contrast image and B picture is a post-contrast image. After IV gadolinium, the T1 image showed rim advancement of abscess wall, which is not usually seen in pyogenic infection. You can see in the A there is no abscess visible, but here you can see there is a rim enhancement of the abscess wall, which is usually seen in the tubercular abscess. So apart from that, MRI can be useful in skipped lesions. That's why we always advise a whole spine screening in the MRI. And other advantages of MRI is extension of disease into soft tissues, spread of tubercular abscess into the epidural space. You can demonstrate a neural compression. You can know the status of the spinal cord. And also serial MRI are used to assess healing of the lesions. This is the anterior type of lesion I showed you in the X-ray picture. The same type of pictures you will be seeing here in the MRI pictures. And usually the collapse of the vertebra and the disc space reduction is minimal or occurs late. Paradiscal lesion is the commonest lesion. There will be reduced disc space and there will be loss of vertebral margins in the early stage and increased prevertebral soft tissue shadow. The earlier signs of the MRI. In central type of lesion, I told in the X-ray, there will be concertina collapse and minimal disc space reduction, which is known as vertebral plana also. Appendicular type of lesion, the posterior structure involvement, which is an uncommon type of tuberculosis, where the disc space usually remains intact, and this can be visualized very well with the this MRI. This is the lesion, the posterior structure, the lamina transversus pedicus. Coming to nuclear imaging, recently they say that these 18F fluorodeoxyglucose labeled positron emission tomographies, CT scan, is also useful. It is useful mostly in assessing the response to antitubercular treatment. So coming to laboratory investigations, in CBC, there will be relative lymphocytosis. ESR is sensitive in 60 to 90% of the cases, usually elevated, but it may be normal in at least 25% of the cases. So it is raised in active stage of the disease, but normal ESR over a period of 3 months suggests patient is in stage of repair. So in 3 months, if the patient is normal, you suggest the patient has repair. CRP is 71% sensitive, but more specific than ESR. Mantoux test is not a reliable test in endemic countries or immunodeficient patients. So coming to microbiology and tissue analysis, these are gold standard methods: bacterial culture, gene export, and histopathology examinations. The aim of culture is to confirm your diagnosis, acquire sensitivity for therapeutic guidance. As osteoarticular tuberculosis is postbacillary, you should obtain samples from deeper tissues like bone and abscess walls. And agar media by Backtech trademark company, these are standard culture media nowadays, and they allow early drug susceptibility assessment. You can know the culture within 3 weeks. But unlike the LJ media, which was taking more than 2 months. Tissue gene expert test, these are the recent investigations, very sensitive. It can detect DNA sequences specific for Mycobacterium tuberculosis, and rifampicin resistance can be known by polymerase chain reaction. You can get the result within 90 minutes. The test has got 88% sensitivity and 98% specificity, almost equivalent to a histopathology examination study. So in biopsy study, it is the gold standard method, the best method, confirmatory method. And WHO has made it mandatory in view of the rising multi-drug resistant tuberculosis to avoid empirical use. But it may not be required in known case of tuberculosis, and where poor resources, the patient can be treated with only classical clinical radiological practice. And the biopsy is preferably done with a CM guided transpedicular route. It can be done by a CT guided route, CT guided in biopsy also. Multiple tissues are taken from the abscess, disc and bone. And there is no need to stop the anti-tubercular treatment before doing the procedure. In histopathology, commonly we find these findings: cageation necrosis, Langerhans giant cells, and epithelioid cells. So, summarizing everything, radiographs are the first line of investigations, but diagnose the disease late. MRI can detect early infection, spread of abscess, status of spinal cord, and also assess healing of the lesion. histopathological confirmation and culture are the gold standard for diagnosis. Other tests like ESR, CRP, white cell counts, tuberculosis, these are only provide supportive evidence. Okay, I have completed most of the usually done procedures, but I have not gone into the detailed serological examination which are not required. So thank you. That's all.
Thank you, Madan sir, for a lucid presentation of investigation methods. Now I ask Kiranda and Dr. Alok to just opine what the examiner wants to know among the laboratory investigation and biopsy also. Kiranda, any comment?
So I can't comment on Professor
Okay.
Madhu's lecture, but just one question is.
I am asking what the examiner, you are an examiner for last more than 15 years. So what you expect as an examiner to ask the postgraduates about the investigatory procedures, okay? Any questions you would like to ask them?
One question very complex, that is why
Okay, I think your net is problem. So Dr. Alok, can you comment?
Well, the lecture was very good, but
Very
we
good,
definitely
yes,
want to know how to diagnose and what to see. So if you see an X-ray and describe it, that doesn't give you the diagnosis. If you see an MRI, then MRI tells you the details, how to proceed for treatment, but it neither tells you about the diagnosis or the prognosis. You have to go for a biopsy or the gene expert test to come to a diagnosis. That is very clear. One thing is there that ATT to give its effect is around 3 weeks. If you stop ATT, there will be resistance. So you cannot stop ATT, and that should not be a question in anyone's mind that should we stop ATT like we do in antibiotics. And
okay,
MRI is the only finding which was 100% foolproof that this is an only tuberculosis that is fine calcification in the paravertebral tissues. Otherwise, they show infection, and we have to confirm it. Thank you.
Well, now invite Dr. Mantu Jain to present his lecture on the treatment of spinal tuberculosis. Mantu, please.
Yes, sir. Thank you, sir. A very warm evening to all of you. And I will be speaking on treatment of tubercular spine. And I will be going through the medicinal treatment as per the RNTCP guidelines, and also tell you what are the indications of surgery, and just give an overview of the type of the surgery, and come to the burning topic, that is the drug-resistant tuberculosis. So actually, what are the big changes that have come through in the last decades as far as management of tuberculosis is concerned? Number one is that with the introduction of Gene Expert and the Gene Expert Ultra, there is now ban on any kind of serological tests in India. TB has not only become a notifiable disease, it has also become punishable if not notified in the year 2018. So the alternate drug regimen has changed to daily drug regimen in 2016, and there are incentives both for the patients as well as doctors on completion of treatment. And the mission of RNTCP is to end tuberculosis by the year 2025. So pre-chemotherapy was the dark age. The orthodox treatment was mainly in the form of recumbence and immobilization in the form of body cast, plaster beds and braces, and patients were treated in the sanatoriums. But post-chemotherapy, there were two groups of surgeons, one who were aggressors and who believed in surgical extirpations for all patients, while some only believed in debridement. So with the MRC trials and observations by Professor Tully, who found that actually many patients, while awaiting fitness for their anemia and nutrition, started showing recovery, and he gave the middle path regimen. So this middle path regimen is based on the fundamentals of, that is, drugs for all and surgery only for few. So if you have to search a book to see what are the guidelines for tuberculosis, then the Holy Bible is the Index Tubercular Guidelines, which was created by the RNTCB in collaboration with the World Health Organization and the Working Committee from the AIIMS Delhi. It is a chapter on spinal tuberculosis as 17. So this not only tells you when to presume a case of spinal tuberculosis, but also tells you how to go about a diagnosis of tuberculosis. Two important things I would like to highlight is that instead of X-ray spine, MRI has become mandatory because it can diagnose the cases earlier. HIV is also mandatory for all patients, and as Professor Sao has already told, that X-ray chest will tell you abnormality in almost 60% of cases. So even though the treatment advisory committee allows you to give an empirical ATT with strong clinical and radiological concerns, but biopsy should be attempted whenever it is feasible, and specimen must be sent for microbiology for pyogenic and mycobacterium tuberculosis along with the biopsy. So all previous categorization have been erased, and now there are only two categories. One is for new and relapsed cases, and other is for drug-resistant tuberculosis. So the daily dose regimen has now a weight bands, and these weight bands, there are at least 4 weight bands for adults and 7 weight bands for children. So this is what RNTCP are giving, and you have to follow these weight bands. And this is to tackle the problem of underdosing and emergence of resistance. But the caveat here lies that the adverse effects are also slightly higher. So the duration of chemotherapy as per the guidelines is for 12 months, which can be extendable to 18 months if the patient is not progressing as required. 2 months of extensive phase of 4 drugs and 10 months of 3 drug regimens. It also gives you a follow-up recommendations. If the patient has a new symptoms, he has to return to you. And if the patient is ambulatory or has a neurological deficit, he has to follow you weekly for his neurological charting. Repeat X-ray must be done at 3 months. Repeat MRI must be done at 6, 9, 12, and 18 months. And even after the end of the treatment, the follow-up must be done every 6 monthly for up to at least 2 years. As I have already told you, TB has become a notifiable disease, and in the year 2018, failure by any healthcare worker to report will lead to jail term for 6 months or 2 years as per the IPC 269 and 270. So this is a case of a tuberculosis diagnosed with biopsy and early diagnosed with an MRI, and he received ATT, and at the 12 months you can see complete healing of his tubercular disease. But the story may not be same for all patients. So when patients after 3 to 5 months, if they do not show appropriate clinical or radiological response, if there is appearance of a fresh lesion or a discharging sinus, or there is a wound dehiscence, and even a deterioration in the spinal deformity, these are the criteria laid by Professor Tully to suspect a drug-resistant tuberculosis. So this drug-resistant tuberculosis could be a monodrug resistance either to a single drug, but more commonly it is a multi-drug resistance when it is resistant to isoniazid and rifampicin. And sometimes it can be extensive drug resistance when it is resistance to isoniazid and rifampicin along with any fluoroquinolones or at least one of the injectable drugs. Now there is a more threatening condition called as a total drug resistance, which has evolved in some of the recent times. So actually, as per the literature, the prevalence of MDR is almost very high, up to 11 to 30% in case of spinal tuberculosis. And as it's a challenge to the spine surgeons because again you need a biopsy right deep from the bone or the tissue, and because it is already paucibacillus, the culture is less, and delay can lead not only to neurological sequelae but also increase to spinal deformity. So any case of drug resistance must be treated at a center which is equipped for treating them and has a good infectious disease control team. But a common regimen as per the WHO guidelines is that at least 5 drugs must be given. Along with pyrazinamide, there are 4 drugs, one from the group A, that is fluoroquinolones, one from the group B, that is injectable aminoglycosides, and 2 from the other core group drugs, out of which linezolid and ethionamide are commonly used. There are only some specific indications for surgery, and these are called as complications of tuberculosis. So whenever there is a deformity more than 60 degrees, or a deformity if it is 30 degrees but has dense neurology like a Frankel A, B, or C, these are the indications for a surgery. So if there is a large abscess which is causing local symptoms such as a retropharyngeal abscess, or there is a deterioration of neurological status during a treatment, then these also require surgical treatment. If there is a pan-vertebral involvement leading to instability, or in children, as Professor Sao described, spine at risk sign, then these are also indications for surgery. If there is no improvement after 6 to 8 weeks of ATT as per the middle path regimen, or when you suspect a drug resistant tuberculosis, then also you have to treat. And one of important is that paradoxical reaction to anti-tubercular therapy. So here, this is the first case where you can see there is a translation, or here there is a bony sequestra. Here there is a retropharyngeal abscess because of the cervical TB. Here there is a spinal tumor syndrome, and here there is an internal gibbus, and all of these are candidates for surgery. So coming to the approach, now there are only 3 approaches, the anterior, posterior, and a combined approach, and all other approaches have become historic. So the anterior approach is ideal for treating 1 to 2 levels of thoracic spine or a single level lumbar spine, and this can be done by a lateral thoracotomy or a lateral retroperitoneal approach. Then in thoracolumbar junction, then you may have to go trans. The posterior approach is used when the disease is a posterior element, or there is a spinal tumor syndrome, or if you want, or if you are going through the transfacetal or transpedicular approach, but here then instrumentation must be done. If the disease is extensive with more than 3 vertebral involvement of the thoracic spine or more than 1 involvement of the lumbar spine, then you have to go do both the anterior and the posterior job. So here is an X-ray, anterior reconstruction was done, and here it was done through all posterior approach, and it's an anterior and posterior job combined approach. So the spine at risk sign, which Professor Sao has illustrated, there are 4 spine at risk sign. Anyone having more than 2 spine at risk sign, they must be operated irrespective of their neurology. And even post surgery, they would require some kind of brace or to cervical TB is though rare, but because the body is small, little damage can produce a lot of kyphosis, or it can lead to neurology. So this is a Minerva's jacket, which is used in case of children or in adults sometimes when there is a tuberculosis of the cervical spine. And in the subaxial spine, you can have put a halo brace. If at all there is a neurology and you have to go operative, then posterior approach would be preferable for a cervico cranial junction, and the subaxial can be approached anterior or a combined anterior posterior approach. Now this is a case of extensive tuberculosis, but there is no instability, no deformity, and no deficit. And on culture, you get a primary MDR tuberculosis. The patient is started on an appropriate regimen, and the patient does well. This is a case of a tuberculosis which was started on a ATT, and after 3 to 5 months, you see there is a lot of deformity, and now the pus culture was taken, and it came out to be a secondary MDR, and he required the anterior and a posterior job. So nowadays we find more and more literature of a multi-drug resistance tuberculosis, and here you can see in this chart that surgeons, they are more inclined towards operative treatment rather than conservative treatment. So we started with the radical debridement and disease clearance, and with the advent of the chemotherapy, realized that tuberculosis was a medicinal disease and there were only some specific indications for a surgery. But now with the re-emergence of the drug resistance tuberculosis, we have gone back to radical debridement and disease clearance, and this is the life cycle of tuberculosis. Thank you.
Thank you, Mantu, for such a nice presentation of the drug therapy and the indications for surgery. Now I ask Dr. Alok and Kiranda to give a comment, not on the lecture, but how to approach on this side from the examiner's point of view. Then questions will discuss in the end. Alok.
Well, I'll definitely comment on Montu's lecture. It was really very good. But sometimes we are in a habit of asking, what are the complications of INH? What is the toxicity of ethambutol? What is the dose of rifampicin? What are its side effects? How do you see its efficacy? So these things also become very important. If it becomes streptomycin, what is its dose? When will you get ototoxicity? When will you get labyrinthine damage? Is it dose dependent? Which drug is bactericidal or which is bacteriostatic? Why a combination? How to avoid drug resistance? These are common things which I like to ask when I am an examiner. Thank you.
Firstly, I must say it's an excellent presentation. It's an excellent presentation by Join, and there is controversy. The questions to be asked in the examination has been told by Dr. Alok Agarwal just now, that regarding the drugs and the toxicities, these are the question asked in the examination. And the controversy for not only for the examinees, but also a general controversy is there. That can be answered by this if you go through this index TB, the RNTB guideline. And but there is a controversy that is often discussed in any spine tuberculosis meeting or symposium. That nowadays it's even the RNTCP, they also tell that you must do a biopsy. So, but there are some scenarios where there is radiologically, clinically and radiologically, according to MRI, you are sure that is a tuberculosis spine. But you have to do a biopsy. But in biopsy, it yields nothing. At that stage, what should we do? That's a question, that is a controversy that is discussed in every spinal tuberculosis meeting.
Well, I feel besides knowing about the regimens, the examiner should know more about these complications like MDR and XDR tuberculosis and WHO guidelines, as you told, RNTBC. The examiner may be tempted to ask about those things. Anyway, thank you. Now I invite Gurudev to talk on the complications of spinal tuberculosis, after which I'll request all the participants to send all their questions so that we can have a lively discussion after the presentation. Thank you. Gurudev, please.
Yeah. Good evening, sir. Good evening, all the senior faculty. It has been a wonderful discussion till now. So I think without wasting much time, I'll be talking on complications of spinal tuberculosis. So as we all know, complications of spinal tuberculosis can be neurological deficit, spinal deformity in the form of kyphosis. You can have sinus formation and TB enteritis. So out of this, we will be discussing on the first two, that is neurodeficit and kyphosis. So the problem statement, probably neurological deficit is the most dreaded complication of TB spine. In underdeveloped countries like India, the incidence can be as high as 20 to 40%, whereas in developed nations, it can be around 10 to 20%. And it is most commonly seen in dorsal and cervical tuberculosis. Sedon et al. Gave this classification in the pre-antitubercular area in 1956, and they classified paraplegia in tuberculosis as early onset when the disease is active, which happens within the first 2 years of the disease, or as delayed onset when the disease is already healed, and it usually happens more than 2 years after the onset of the disease. So as it has been discussed earlier, the main cause of early onset paraplegia is because of liquid abscess, the pus, the granulation tissue, and occasionally it can be because of tuberculous myelitis, spinal artery thrombosis, and tuberculosis arachnoiditis. Whereas the late onset paraplegia is usually because of recrudescence or reactivation of the disease and pus formation, but usually it is due to the compression of the cord by a kyphotic deformity in the spine causing an internal gibbus. And the risk of late onset paraplegia is more so if the kyphotic deformity is more than 60 degrees. So Tully et al. Gave this classification in 1999, and they classified the stages of neurodeficit in TB spine into 5. In the first stage, where the patient is unaware of the neurological deficit, and progressively as the deficit worsens, you have increase in the grades, where in stage 3, the patient is already paraplegic and he is non-ambulatory. Whereas in grade 4, in addition to paraplegia, patient is having flexor spasms, bladder and bowel involvement, and sensory deficit of more than 50%. Now, there were some drawbacks in this classification, and Dr. Anil Jain from GTB Hospital in Delhi found that it does not describe all the motor and sensory findings that is seen in tubercular neurological deficit. And so he gave a revised classification in 2005, where he graded this deficit into 5 grades, where the grade 1, where the patient was unaware of the neurological deficit, and you can detect this by the presence of UMN signs. Grade 2, where there is spasticity but he is ambulatory. Grade 3 is where the patient has got sensory impairment only in the lateral column. Grade 4, where there is involvement of lateral and posterior column, and so sensory deficit and because of this involvement of these tract. Whereas in grade 5, there is bladder and bowel involvement and flaccid paralysis. These classifications may be asked in the exam, so probably it is worthwhile remembering these classifications. Now the question comes, can we predict neuroworsening in active spinal tuberculosis? Because probably the best way to treat neurodeficit is preventing the neurodeficit. And studies have shown whenever the kyphosis is more than 30 degree, or you can see a T2 hyperintense signal in the cord, probably you are looking at an impending neurodeficit. So these are the patients which we should catch hold of them and give intervention. Now, the indications of surgery in tuberous spine in the presence of neurological deficit is debatable. In active disease, a lot of people try conservative management even in the presence of neurological deficit, but in today's date, probably it is wiser to offer them surgery in the presence of neurodeficit. But classical description is that neurodeficit, which is developing during the course of conservative treatment, or when the neurorecovery is not present in spite of a fair trial of conservative treatment, they should be offered surgical correction. And patients who have rapid onset paraplegia, severe paraplegia because of with flexor spasms or complete motor and sensory deficit should be offered surgical correction. Now, as has been discussed by my previous speaker, Dr. Montu, the surgical options can be either an anterior surgery, a posterior surgery, or a combined anterior and posterior surgery. The classical, when we were resident, the classical surgery that was described for anterior approach was the modified Hong Kong procedure, where you do a radical anterior debridement by removing all the debris and granulation tissue and then reconstruct it with a bone graft and then stabilize with an anterior instrumentation. Later on, people found that there was morbidity of the procedure was probably more, and people started moving towards posterior procedures. The classical posterior procedure described earlier was the anterolateral decompression, where you do not have to instrument and you can do removal of the pus through an anterolateral approach. But the problem is it does not ensure a very good decompression. Today's date, transpedicular decompression and instrumented laminectomy have been the gold standard. Isolated laminectomy is contraindicated, and this should be noted because tuberculosis is basically an anterior disease. So the posterior structures are the only thing which is stabilizing the spine. So if you remove the only stabilizing structure, you can have catastrophic progression of kyphosis. So isolated laminectomy should always be discouraged in patients with tuberculous spine with neurological deficit. Anterior and posterior surgeries can also be done, but in today's date, where you can do all anterior reconstruction from a posterior approach, this also may not be needed in all cases. So the prognosis has to be discussed with the patient. There are some patients who have very good prognosis with your surgical treatment, especially young patients who have good nutritional status, where the cord is preserved, and when you can drain a liquid pus, they will have a very good prognosis. Whereas patients who are old, debilitated, who have a long-standing neurodeficit, or where there is cord myelomalacia, and you can see thick pus or fibrous tissue surrounding the cord, these patients will probably have a poor prognosis and have to be counseled accordingly. Now, coming to the next complication that is seen in tuberculous spondylodiscitis is the tubercular kyphosis. So the problem statement, around 3% of patients with TB spine will develop severe kyphotic deformity. And among this, all the patients will have on an average mean increase in their spinal deformity by 15 degrees. Patients who have deformity more than 60 degrees will probably have late onset paraplegia. So this can cause multiple problems. And as been discussed by my previous speakers, the kyphosis can be of various types. You can have a gibbous where there is involvement of one or two vertebra, or you can have a knuckle, or you can have a round kyphosis. But the basic question comes, why does kyphosis actually develop in TB spine? Now, as we all know, tuberculosis basically involves the anterior part of the body and the adjoining disc. So gradually, as the disease progresses, the vertebral end plates weaken. And as we have a normal kyphosis in the thoracic spine, the weight of our body will be more along the anterior aspect of the vertebral body. So the vertebral body will tend to lose more weight anteriorly than posteriorly. So this will accentuate the already pre-existing kyphosis in the thoracic spine, and you can have a very debilitating kyphosis. Now, Rasakar et al. Did a study on these patients, and they started ambulatory chemotherapy on these patients, and then they studied the progression of neurodeficit. And they found that they could predict the amount of final deformity at the end of 5 years if they knew the amount of initial vertebral body loss. So the factor that probably determines the amount of deformity a person will develop is the amount of initial vertebral body loss. And they devised a formula for that, y is equal to a plus bx. This is a very important formula and is often asked in the PG exams, where a and b are constant. A is 5.5, b is 30.5, and x is the initial vertebral body loss. With this formula, he was able to predict the final angle of deformity in 90% of cases. Now, people often ask, how do you calculate this initial vertebral body loss? There are various formulas of finding it out. The easiest one is probably, if you see, for example, I'm showing over here, this is the, suppose there is a lesion in D8 and D9. Now, suppose the D8, you see there are half of the vertebral body is lost. So your the vertebral body loss is 0.5. Whereas D9, you again see around 70% of the vertebral body is lost. So that the loss is 0.7. So the total vertebral body loss is 1.2. So with this formula, you can calculate how much will be the final deformity. So suppose when you have a total vertebral body loss is around 2, you will see that when you put these parameters, you will have a final deformity of in and around 60 degrees. And Tuli sir have shown that whenever the final deformity is more than 60 degrees, there is a very high risk of developing late onset paraplegia. So you can catch hold of patients who have initial vertebral body loss of more than 1.5 or 2 to have very severe kyphosis later on, and they should be addressed with surgical management. Now, Dr. Rajsekharan et al. Also during his MRC trial found out that 15% of patients who are managed conservatively will have a deformity of around 60 degrees at final follow-up. And the peculiar thing was most of these patients were actually results of childhood spinal tuberculosis. Now, so it is very important for us to know how kyphotic deformity progresses in adults versus in children. Now, this graph, you can see the red graph, the red line is for the children and the blue line is for the children. Now, it has been seen that during the active phase of the disease, the kyphotic deformity progression will be more in children than in adults. That's expected because the bone in the children is cartilaginous. But then a very peculiar thing happens once the disease is healed. Now, with time in adults, as the disease is healed, the deformity does not progress. So deformity stabilizes. But in adult children, you can see a very varied pattern of progression. Few of these children will have deformity improvement. Few of these will have worsening of this deformity. Few of them will have stabilization of the deformity. So it was, if you could realize that the way the pediatric spinal deformity behaves is quite different from adult spinal deformity. So children will have higher degree of deformity at presentation. There will be a greater tendency for collapse during the active phase of the disease, and you can have a very variable progression once the disease is cured. Now, this is a very good example of this. Now, this 3-year-old child had tubercular involvement in the thoracolumbar spine. Now, at the end of the disease healing, that is at the end of 1 year, he had a residual kyphosis of 40 degrees. Now, you expect that this kyphosis should remain constant because the disease has healed. But when you see this patient at the end of 5 years and at the end of 15 years, you could see that this kyphosis has progressed to almost 130 degrees in 10 years. So this is catastrophic. So deformity in pediatric spinal tuberculosis behaves like there are two diseases. One in the acute phase, which is like a normal infectious disease, and in the healed phase, because the deformity is being modulated by biomechanics of growth of the vertebral body. So Dr. Rajsekharan et al. During his MRC trial studies found that the natural history of tubercular kyphosis in children can be 3 types. 1, 44% will have improvement in kyphosis with growth, 39% will have worsening of kyphosis with growth, and 17% will have probably no change in kyphosis with growth. Then this question comes, why do some children improve and others deteriorate? Now, when he had a close look at all the patients post-healing, then he found then you can have 3 patterns of restabilization. One in which the vertebral body loss was less than 3/4. In this, the facet joints remained intact and they had a good result. In the next group, they found and the vertebral body loss was from 3/4 to 1.5. There, they had subluxation of a single facet joint. Whereas in the type C, they had vertebral body loss of more than 1.5 and they had multiple facetal subluxation. So the key probably is this facetal dislocation. Now, as we know, TB spine is an anterior disease. So we all know there will be a lot of destruction anteriorly, but we forget to look at the posterior structures. Now, once the destruction in the anterior vertebral body progresses, there will be facetal subluxation. So once the facetal subluxation happens, there will be global instability because there is both anterior as well as posterior involvement. So that signals the depth of the column, and that will precipitate a malignant progression of the curve. So that the key to identifying patients who have rapid progression in spite of the disease healing is facetal dislocation, because that is the point of no return. So then the question comes, can you identify these children who will have relentless progression of kyphosis? So in other words, can we identify the signs of facetal dislocation? Yes. Dr. Rajsekharan et al. Has given these 4 signs, which have been very popular, and I think every resident must know of these signs. So he described 4 signs which are not a continuum of severity. So they are posterior separation of the facet joint, posterior retropulsion, lateral subluxation, and toppling sign. For the benefit of the resident, I would like to describe each of these signs. When you look at the X-ray and you see the facet joints are not overlapping of each other, this is known as separation of the facet joint. You give 1 point to this finding. The next is posterior retropulsion. If you draw a line along the posterior vertebral body of the upper normal vertebra and the lower normal vertebra, and if you find there is the jumbled mass of affected vertebra lies still behind this line, this is known as posterior retropulsion. This also has 1 point. The third is lateral translation. If you draw a line along the pedicles, the superior pedicle will not pass through this line. This is lateral translation. The fourth is the most popular, that is toppling sign. The inferior normal vertebra, if you draw a line along the anterior surface of this, it will pass above the midpoint of the superior normal vertebra. So this is again toppling sign. So patients who have multiple spine at risk sign have very severe progression of kyphosis. In his series, Dr. Rajsekharan found that 10% of his cases had exponential progression to produce a severe kyphosis of more than 90 degrees. He called them buckling collapse. Now, these patients had a very peculiar radiological feature. Here, at the apex of the deformity, the vertebral body became horizontal. And as the weight of the body is not passing through these vertebrae became taller. So they can have, the spine almost became like a parabola. And as you know, there was acute tenting of the cord along this kyphosis. And in some studies, they have seen when you increase this length by 1 centimeter, the stretch of the spinal cord could be around 3.8 centimeter. So these are like a ticking time bomb. At any point of time, these children can come to you with an acute onset neurological deficit, and these need early management. So looking at these cases, he found that what are the risk factors for buckling collapse, and he found patients who had TB before the age of 70 years, who had thoracolumbar involvement, who had initial vertebral body loss of more than 2, or who had more than 2 spinal risk sign, had a very high risk of developing buckling collapse. So the best way to prevent these kyphotic deformities is preventing them. And this is done by diagnosing tubercular involvement of the spine early, before the kyphosis sets in, and keeping a very close watch on the most susceptible patient, that is the children. And kyphosic correction is easier when you do it in the active stage of the disease. And probably the one point that we can take home from this lecture is that no child with TB spine should be lost to follow-up till the growth period is over. Now, the indications for surgical correction of tubercular kyphosis can be severe when the amount of deformity is more than 60 degrees, when the kyphosis is progressing under your observation, or there is an associated neurological deficit. Now, the approach can be 3: anterior, posterior, or combined anterior and posterior. And anterior procedures are not very preferred now, because it is actually very difficult to do a kyphosis correction from an anterior approach, because you have to go there in a depth, and it is very difficult to correct them, and you won't get a very good correction, and there is higher risk of neurological deficit because you're almost blindfolded when you're operating at the depth. So anterior surgeries for kyphosis correction have slowly become obsolete, and the mainstay of treatment is either posterior or anterior plus posterior. I'm not going to discuss.
You're way ahead of your time, please.
2 minutes. I'll just only discuss internal kyphectomy and the spinal osteotomy. Internal kyphectomy is a very simple procedure. What you do is, when the cord is being indented over the internal gibbous, you just remove that gibbous, the cord will be flattened, and the risk of deficit will be less. Now, the mainstay of treatment is a vertebral column resection, where you put pedicle screws, put temporary rods, do a laminectomy, and then you remove the internal gibbous like in the previous procedure, but then you fill up that gap with a mesh cage. So the people often ask, what is the best treatment for osteotomy for post-tubercular kyphosis, whether it is a PSO, VACR, or a Smith-Peterson osteotomy. Now, this good classification given by Dr. Rajsekharan has shown that most of the patients who have post-tubercular kyphosis have both anterior and posterior column deficiency, which is a type 3 deficiency. And these patients will do well if you give them a vertebral column resection or a pedicle subtraction osteotomy. So you can have complications because of tubercular kyphosis like costopelvic impingement, cardiorespiratory complication, spinal stenosis, or paraplegia. So costopelvic impingement happens when the rib cage impinges on the iliac crest. So I think with this, we'll come to an end of this presentation. The take-home message from my talk will be that early identification and management can prevent catastrophic neurological deficit. Kyphotic deformity will progress even after the disease is healed in children. So you should have a clean look on these patients. You should always look for spinal risk sign in kids to prevent post-tubercular kyphosis. And vertebral column resection is the workhorse of post-tubercular kyphosis correction. In the end, I think I must pay my homage to these three people who have done the maximum work, and all our knowledge in post-tubercular kyphosis or deficit is because of this: Professor Tuli, Professor Rajsekharan, and Professor Anil Jain. Thank you.
Hello. Thank you, Gauradev, for a nice lecture outlining the management in complex like tuberculosis. And now I ask Alok to give some comment, and Kamalda. Then there is a MCQ. Bikram has planned for the postgraduate students. After we'll continue with the question answers.
After discussion, we'll launch the MCQ.
Okay, that will be better. That will be better.
Okay, sir.
After this, we'll start the question answers. There are many questions. Besides, the panelists would also like to discuss more things about the common approaches to tuberculosis and other nuances.
Okay,
so
sir. That time I will launch.
Sure.
Thank you, sir.
Well, Kiranda, if you want to comment on this last lecture, anything you want to add, the examiner should know and you would like to ask, and then I'll go for question answers. There are more questions.
Thank you, Dr. Gurdeep, for your presentation. But this is a presentation for spine surgeons. This extensive tubercular complications of the tuberculosis spine is not usually discussed or asked in the exam. The main point is the internal gibbous. That is the one point that is the commonly discussed, and what are the surgery indications for surgery that have been described by you and your previous speaker also. Okay, Dr. Agarwal, and then we can. I think we are lagging behind time. We can.
There are only two things which I would like to tell. That sometimes we like to ask that how will you treat a patient with paraplegia? So that becomes a question we ask: the conservative care, back care, nutrition, sexual rehabilitation. The second thing is we sometimes ask that if you are treating a patient conservatively, how will he progress for collapse? If you are operating without bone graft, how will he progress? Or if you have operated with graft, how will be the progression? And these things also should be come out in the lectures. But otherwise, he has taken it wonderfully well. And I think it is meant for the spinal surgeons. Thank you.
Well, now I'll be asking few questions. Now first for Bikram. Do we need to check for movement? This is a question by Dr. Devi Prasad Nanda. Do we need to check for movements of dorsolumbar spine in a spinal TB case with paraplegia involving DL spine?
So in a paraplegia, practically it is impossible to get any movements of the spine. So if I have told that if patient can be able to walk, see the gait, if the patient is do some movements without any pain, ask for any movements, otherwise do not do any active movement to the patient.
Well, there is one more question for you, Bikram. What is the importance of bulbocavernosus reflex?
bulbocavernosus reflex, usually it is lost when there is a bladder involvement also, because there are same root value supply, both the cases. In spinal injury especially, the return of bulbocavernosus reflex, we usually presume that it ends the spinal shock. So we need to check for it whether there is any injury. But in case of a routine examination of all the reflexes, we should know and do also the anal bulbocavernous reflex and cremasteric.
Well, there is one more question for Madan sir. As the spinal TB is always secondary, should we do a complete respiratory examination and describe during examination? Madan sir. As the spinal TB is always secondary, should we do a complete respiratory examination and describe during examination? While presenting, should we describe in detail?
No, you should not describe in detail the respiratory. Why should you do? It is not required normally.
One question for Monto. Should we stop anti-tubercular medicine before taking a biopsy?
Biopsy is must. If possible, ATT should not be started if the biopsy has not been done. So even after proven tubercular, only ATT should be started. If you have already started ATT, then probably after some time you will, I think that the bacteria will be killed, and as already it is a paucibacillus, the chances of getting a negative biopsy is very high.
Well, one question
Hello.
for Gurudev.
Yes, sir.
Any comment by the panelists on this?
Dr. Join, that was the question I asked you, that it's not always possible to prove that is a tuberculosis because the biopsy may be negative, because the possibility disease, the FNAC also be negative. So in that case, what will we take? So that's a controversy. So we should start after it is established, the diagnosis is established as tuberculosis spine. But there are scenarios that where the biopsy is nothing, but it is clinically and radiologically it's tuberculosis spine. In
Well,
that scenario, what will?
Also, I have to ask one question. Even tuberculosis organism has been found in excised tissue even after a year of chemotherapy. Do you think this is a case of failure, Mantu? Do you think it is a case of failure of treatment, or they are incidentally present like that?
You are telling that the tuberculosis is still present after a year?
Yeah, even after a year when you do a biopsy of excised tissue and it has been found to be present.
I'm not pretty sure, sir, why somebody will do a biopsy after a year if the treatment was okay.
Well, for example, Gurudev wants to do a revision surgery because of late onset paraplegia, and he had sent the tissue, sorry, and found that incidentally it is there. Or maybe for another disease, you are doing a biopsy of vertebra and found that.
I'm not sure about this, sir.
Alok, would you like to comment, or any other panelist?
What question was that?
Question was that even if you do sometimes MTB organism, they are found even in excised tissue after 1 year. Okay.
Yes, there are dead bacteria found even after years after the treatment.
Yes, how you differentiate dead and live bacilli in biopsy specimen?
You cannot differentiate in a histopathological specimen, but the bacteria remains there for years together even after the completion of the treatment.
Well, one question for Gurudev. Does late onset paraplegia always occur in healed state or can occur in active stage also?
Late onset paraplegia, if somebody is having after 2 years of the onset of disease, it usually means that either there has been a reactivation of the disease. So you get an MRI and you see a fibrous tissue at the apex of the disease there where it was initially involved, or it is because of solid kyphotic deformity.
Yes.
So it can be because of reactivation of the disease. Possible.
How do you clinically differentiate this late onset paraplegia, which is usually due to a internal gibbous? Suppose two situations can occur. We have a slow progress of the paraplegia, late onset, and sudden onset of paraplegia, late onset. How to differentiate whether it is what is the cause?
See, whenever I think MRI will help you in identifying what actually has led to this neurological deficit.
Okay.
So, as I said, when you have a kyphotic deformity of more than 60 degrees and you see there is cord signal changes, that means this deformity has happened, this deficit has happened because of the compression of the cord. So, it is like any compressive myelopathy. So, that is the cause over here. And if you see, you don't see any abscess cavity over there, you don't see any soft granulation tissue over there. So that means this is not a reactivation of the disease. This is because of the compression of the cord from solid bone, and that is because of
Well,
the
for
kyphotic
example, I am
deformity.
asking for the examiner, I am asking clinically, how you differentiate a late onset paraplegia? What is the type? Any tips how to clinically identify that possible it is because of internal gibbous or late onset without a active recrudescence?
Yeah. So like if it is a recrudescence, patient would have been completely asymptomatic, and if the patient does not have reappearance of constitutional symptoms, that means it is not a reactivation. So if the patient does not have constitutional symptoms, patient is otherwise ESR CRP is normal, and only thing that you note is a deficit, then it is because of compression from a healed disease. It is not an activation.
Well, anything, Alok, you want to comment?
Sometimes ischemia of the cord. The blood
Yes,
vessel also
yes,
gets
yes.
blocked in the late stages. And that is also given as a cause.
Well, clinically, I feel when there is a late onset paraplegia, because of this bony gibbous, they're usually tardy. When you clinically examine, you find patchy sensory loss or motor loss, which is not uniform. If it is ischemic, then there will be sudden localized loss. Okay,
exactly.
That is the region how you clinically differentiate about this slow onset of paraplegia. That's called tardy, just like tardy ulnar nerve palsy. So because of stretching of the cord, so neurological involvement will always be patchy, it will never be uniform.
And another thing is really the symptoms. The pain usually is absent or very mild in case of late onset
Okay.
paraplegia.
Yes.
That is also important.
So there is one more question for Madan sir. Why does radiological recovery lags behind clinical recovery in tuberculosis?
Yes. Actually, even if we are doing the radiology, imaging, everything, they are all shadows. Even radiology has got only 15% sensitivity, and your MRI has got only 90% specificity sensitivity. So, unless the lesion is quite evident, sufficiently evident, you cannot at least accept it as a positive findings. So usually what happens, that is why in the imaging and radiology, the findings come very late, and symptomatically the patient becomes better before that. That is the reason. Maybe in the later, within another 10 years, you may get some other investigation which can catch the disease early, or any assessment can be done early. But until now, it has not been possible.
Same thing I'll also ask. When you take a repeat X-ray or MRI after 3 or 6 months of the treatment, you always find that there is deterioration of radiologically in the tubercular affection of the vertebra. Why it's that?
That's why it is written.
Deterioration.
Well, X-ray usually after 3 to 6 months, if you take another X-ray or MRI, they show more deterioration radiologically, even though ATD is going on progressively well. Yes, sir, diminished symptomatic improvement, this thing occur. This is the standard thing written in the books. So
Yes.
why it is that? Any?
It's difficult to say. See, best thing is to assess the patient clinically. Clinical assessment is the best thing. Clinical
That's
and
right.
your
I understand,
laboratory
but
parameters.
why it shows that there is radiological deterioration during treatment initial stage?
Sir, I would like to add that first of all, this clinical improvement is because of chemotherapy, and radiological improvement is because of your micro and pathological improvement. So that takes time. It is not for tuberculosis, but even in case of metastasis or any other disease also, radiological always lags behind clinical treatment. And if there is a deterioration, there may be it is lagging behind, but there is some improvement. It is not that it is worsening. If it is worsening, then you have to think about the paradoxical reaction or a drug resistant tuberculosis.
Well, if I may ask to maybe to, there is one question for Jitendra, then I'll come to other things. Is there any role of bone scan in TB spine? How to differentiate port spine from metastasis to spine?
Actually, metastatic spine, it is, you will have the history of cancer, primary cancer, and it happens in the old age. And metastatic usually involves. Hello.
Yes, yes.
You are asking the differentiate between TB spine and metastatic.
Yeah. By bone scan.
By bone scan.
Is there any role for bone scan?
In TB?
Yes.
Yeah. Bone scan nowadays is used to know the end point of the treatment. Suppose after around 10 months, we repeat the MRI to end the ATT. And similarly, bone scan is used to know to end the treatment of tuberculosis. It is the most specific. It is more specific than MRI to stop the treatment.
Hello, Vimal.
Hello.
Sir.
I also told in my talk that this PET scan sometimes is done to assess the healing of the disease.
Healing.
For assessment of the healing, PET scan can be useful. Can be used. So it can tell the end of the disease.
Sir, one thing I would like to add is that nowadays tuberculosis is non-contagious skip lesions. So whenever you have a skip lesions, you must have a lot of inquisitivity to find out whether it is metastatic or not. And then the bone scan can play a role. And metastatic is more of the posterior element involvement than actually the body involvement. So in that way also you can know whether the correlating MRI and the PET scan will let you know whether it is metastatic or tubercular.
Well, there is
one question. I wanted to add one thing.
Yes.
Can I speak?
Sure.
So the main aim of the biopsy was not to get a diagnosis of tuberculosis, because that is not coming in more than 50% of the cases, but you at least rule out a metastasis. That was one part. Second thing, for MRI, it will show you the damaged area, but you can neither come to the diagnosis nor get to know whether the patient is recovering or not. Recovery you see clinically and by neurological improvement only. And then when you come to bone scan, the technetium scan and gallium scan, they are okay. But if you really want to be specific for infection, then go for indium 111 scan. And that has been mentioned with leukocytes to be giving a diagnosis of infection. And that is from Campbell, the 3 points which I am telling. Thank you.
Well, there is one question for Bikram. So is cold abscess actually cold? And what makes it hot?
If the cold abscess becomes superadded with infection after repeated aspiration, it may become an active abscess or a hot abscess. Otherwise, the signs of inflammations are usually absent. That's why it does not irritate to the psoas muscles. The fixed flexion deformity may not be present in case of a TB psoas abscess related to the tuberculosis. So the cold abscess may be hot, may becomes a hot abscess if it gets infected subsequently by the repeated abscesses.
Well, one for Gurudev. Why does a spinal tuberculosis, if there is a tuberculosis of hip, it usually heals with fibrosis? but spinal tuberculosis usually heals with a bony ankylosis. What is the reason for this?
I'm sorry, I don't know. I think
Actually,
somebody.
when a TB hip heals, it usually leads to bony fibrous ankylosis. But when a spinal tuberculosis heals, it usually leads to bony ankylosis. Okay, so why is that? What's the reason for this?
So actually, that the reason is not written anywhere. I think because of the blood supply, spine has a enormous blood supply, and the movement is less as compared to hip joint. Where there is more movement, there will be more fibrosis. Where there will be less movement, there will be solid union. This may be an hypothesis, but the reason is not written anywhere.
Sir, I think that the hip has lot of cartilage surfaces. So even in diseases, the subchondral bone is not exposed as much as in spine, which is cancellous, and the cartilage end plate is very thin. So naturally, the bone surfaces are exposed, and whenever there is a bone surface exposure, it will lead to bony ankylosis, which is almost most of the surfaces are exposed in spine, but in hip, only some of the area of the cartilage are exposed. So that I believe that may be one of the reasons.
Well, actually, it occurs when there is a paradiscal lesions, because there is a telescoping also. Normally, because of telescoping, you get more compression and bone surface are exposed. Some books write like that. Okay, there is one for Monto. Is there any advantage of middle path regimen that we usually follow in government setup?
Sir, it is now middle path regimens are like if the patient, now we have clear-cut indications of patients who want surgery and who do not want surgery. So if at all the patient is a candidate for surgery, he has to be operated. And that middle path regimen actually has now become very obsolete. But there are some clear indications when you need to operate. Sometimes if the waiting list is long, then obviously the patient has to wait, and that is not by 3 weeks or 6 weeks. It may be longer or it may be shorter. But I don't think that we follow the middle path regimen to decide whether after the 6 weeks we are going to operate or after 3 weeks we are going to operate.
Well, there is one question for Madan sir. How do you differentiate between Anderson lesion and tubercular infection in ankylosing spondylitis?
Anderson lesion and tubercular lesion.
Yes.
Anderson lesion, see, in Anderson lesion, there will be osteolysis and there will be a pseudoarthrosis type of lesion, but without any signs of inflammation, usually around that area, radiologically and also in MRI.
In tuberculosis, you will get soft tissue. In Anderson, you will not get any soft tissue involvement.
Soft tissue abscesses.
Abscess
Soft
wall.
tissue abscess or inflammatory things will not be there.
Well, Madan sir, there is one question. What to look for in axial view of MRI in TB spine?
Yes, in an axial view, the most important thing is the amount of compression to the spinal cord, epidural compression, epidural abscess, and also anteriorly how much prevertebral or paravertebral abscess is there. Should see these things.
Achha, there is one question for Gurudev. What is the most commonly used approach to treat thoracolumbar TB spine surgically?
Right now, since 2008, we are using mainly the posterior approach because we can do all the anterior reconstruction from a posterior approach. Before that, it was mainly anterior, but right now, almost more than 90% of cases, we do posterior only.
Well, there is one question, maybe Gurudev. What classification to be used for port spine without paraplegia? Because there are so many classifications. What, when you appear for the exam, what is the best classification you should give to satisfy the examiner?
Classifications depend on like what you want to divide or classify or describe. Like if you are describing neurological deficit, you have to use a Thule classification. If you want to describe the amount of deformity that the patient is having, you have to describe according to the amount of kyphosis. And other than that, you can use whether it is an active disease or it's an healed disease. and that is the most you can use for classification.
Well, there is one question for Vikram. Yes,
Simple or
yes.
complicated?
Yeah.
Sir?
Simple or complicated like
Simple or complicated, that also you can use.
There is one question by Vikram. What is the autonomous and autonomic bladder in paraplegia? How you differentiate?
Yes. Autonomic bladder is where there is a upper motor neuron palsy, where the lesion is more above than D11, where the bladder fails to store. Patient will complain that repeatedly some amount of urine is passing involuntarily. But in lower motor neuron type of bladder, that is an autonomous bladder, where the lesion is below the L2, where there is a failure to store, a failure to empty. That means the urine will be accumulating, and suddenly it gives way by some mantle pressure or automatic. So there are two different entities, and if the lesion is between D11 to L2, there is a mixed variety of symptoms.
Okay, there is a question by Dr. Tanmay Mahanti. During examination of a case of suspected spinal tuberculosis, if the student finds clinical features of tuberculosis of lungs, for example, pleural effusion, cavity with signs of mediastinal shifting, I think he should describe it. What is the opinion of the panelists, Alok and Kiranda?
So many times primarily it is involved the respiratory system. So if there is prominent features or positive findings in respiratory system, then a student must mention that.
Alok, what is your opinion?
Well, I always promote a general and systemic examination. And examination of the respiratory system is routinely done. So if the findings are there, it is better to speak them out. You cannot go for local examination directly without going for a general examination and systemic examination, especially in the long case.
Well, there is one question for Mantu. What is the most potent anti-tubercular drug? And can it be prescribed alone?
Sir, monotherapy is banned by RNTCP. So it is always a combination therapy. Even in case of MDR or a failing regimen, again monotherapy is banned. So I think, I'm not pretty sure, but I think rifampicin or isoniazid could be one of the most potent drugs. Now streptomycin is almost out of order. We hardly prescribe streptomycin to any of the patients.
Well, INH is the most potent, but it should never be prescribed individually. Always a multi-therapy is essential. Well, thank you, Kiranda. We'll ask a few more questions, and then there is one for Jitendra. What is that question? What is heart tubercle?
Heart tubercle.
Yes, yes.
If there is no caseation necrosis, and
Yes.
it is after anti-tubercular, if it is healed, the lesion is healed after ATT, or there is no caseation necrosis, it is called heart tubercle.
Well, after chemotherapy, early chemotherapy, etc., you find that. Well, there is another question for you, Jitendra. What is the mode of transmission of atypical mycobacteria, and how you differentiate from mycobacterial tuberculosis?
Atypical mycobacterium bovis, you are asking? Mycobacterium bovis?
There are many types like cancer C and lot many things.
I think I'm not sure, but bovis is, I think, for the milk and cancer C.
Okay, Alok, can you put some light on it?
Well, the behavior becomes slightly different when they are causing it, but you cannot differentiate mycobacterium tuberculosis with bovis. They are the most common ones. And histopathology can only give a diagnosis, I feel.
Well, they are transmitted by a local injury. Direct contact, yes, yes. Direct contact.
Atypical mycobacterium, sir. Sir, atypical mycobacterium may infect in case of immunocompromised host, or if it is normal host by the direct inoculation or contamination. And it is usually associated with bursitis,
Well, yes, we'll have one or two more questions, then we'll say. There is one for Gurdev. Do all cases that are decompressed need instrumentation?
No, it depends on the type of instrument decompression you have done. In earlier days, when people used to do anterolateral decompression, there was no instrumentation which is necessary because you are not adding further instability by removing the posterior elements. But nowadays, when you are doing either laminectomy with instrumentation or you are doing transpedicular decompression, it usually involves some amount, needs some amount of, you are creating some amount of instability. So better to instrument.
Well, the final question to
Kiran, I just wanted to
yes.
answer this question. Well, I was going through the Tulis' new book of tuberculosis. So he's clearly showing that if you have done a decompression and you don't do grafting, then the collapse will be more compared to instrumentation with grafting. So you should always do grafting along with instrumentation. If you have done a decompression and you just leave it without grafting, then there will be further collapse. So that is mentioned in Tulis' book. He has found that the conservatively treated patients are collapsing less compared to decompression, in which there is grafting not done.
Correct.
Even Tolle's book says if there is a gross kyphosis and person is not having neurological affection, then they don't go for surgery and instrumentation, decompression. If it develops some neurological effect, then you go for the decompression.
No, Tullis changed in his newer book. Tullis nowadays saying that surgery is important, but even the hospital setup, you are not finding timing for doing it, then only you go for it. But if there is neurological deficit, better go for surgery. That is the newer version.
Well, final question to Kiran Da, because he is in the hotbed of corona now. So effect of corona on port spine.
It's like other all the indications of all the fields of surgery, including orthopedics and others also. Only we have to operate on the emergency situations where we must do operate. Otherwise, we should not operate on this on the case spine patient, which can be treated conservatively. We should try to treat conservatively, and exceptionally those indications are on 7 points nowadays regarding instability, regarding neurodeficit. But nowadays the acute onset of neurological deficit with even with on chemotherapy or rapidly progressing neurodeficit, mainly is the only indication for doing spinal surgery in this COVID situation.
Well, any final comment by the panelists, after which I will request Shashwat to give vote of thanks to all the
I wanted to tell you one thing for this corona. A study has been released from UK only 2-3 days back, and the rate of mortality in patients with corona positive is 3 times more compared to the normal people being operated. So you have to tell the patient a prognosis if he is corona positive, that the chances of death are more in you. So that's it.
And if paraplegia, they have more chance of dying with respiratory problems. Okay, I thank you all on behalf of things, and then I'll ask Shashwat to give a formal vote of thanks.
Sir, before Dr. Shashwat, we have launched the polls and they have given the answer. Now, I just relaunched the polls to the panelists. So you can see that and
give the opinion whether it's right or not.
Yeah.
Vikram, you are the boss.
Sir, I have put some questions, sir. I'll give answers, which is not the blood supply. So this pair of anterolateral vessels is not the answer. All three are the posterolateral vessels are there. Anterior, medial, longitudinal trunk is the answer. Artery of the Adamski is the answer. So A is the wrong.
But most of people has given B.
A is the wrong because there is no pair of anterolateral vessels in spinal cord blood supply.
Then let us see what was the answer by most people. Well, Well, next question, Vikram, because it's already 8:15. So
relative demand, metabolic demand of gray matter is more than white matter is right. White matter is wrong. Metabolic demand. The answer is vanishing. The question is vanishing from my screen.
next question.
Sir, the questions are not there on my screen. So I have put 5 questions, sir. Yes. The metabolic demand of gray matter is more than the white matter is right. C is wrong. B is wrong. Thoracic area gets the thoracic area gets late blood supply, and this is also wrong. Then the third is medullary feeder radicular arteries of the cord reinforced longitudinal lateral trunk by circular exposure, except lateral sacral artery is there. Batson's arterial, there is no Batson's arterial pressure. This is wrong. And all fifth lumbar artery, lateral sacral artery, heel lumbar artery, middle sacral artery, all are the femoral vessels. Next question is the distribution point of segmental artery lies at. Usually it lies at the intervertebral foramen. Usually it lies at the intervertebral foramen.
Vikram, so this was the last question.
Yes, yes. Well, Sirsandu, sir, if you want to speak anything.
So this question, Miller asthma is due to interstitial lung disease, thoracic spinal tuberculosis, asbestosis, and cervical spine TB. Miller asthma is due to recurrent laryngeal nerve palsy that occurs due to cervical spine tuberculosis. These are the questions, sir.
Okay, thank you, Vikram.
Thank you, sir.
Yeah, Andrew.
Yeah. Thank you, sir, for a very interesting session. And I would like to invite our zonal manager, Mr. Joydeep Jordar, to say something on the occasion. But before Joydeep sir, I would request Shashwat sir to say a few words to the panelists. Shashwat sir, please.
Thank you. We are genuinely grateful, and today's session was honestly very stimulating and interesting. And so we genuinely thank all the speakers, starting from Professor Madan Mohan Sao to Dr. Mantu Jain, Dr. Vikram Kara, Dr. Gurdeep Das, and Dr. Jitendra Raut. We are also grateful to Professor Alok Agarwal sir and Professor Kiran Mukhopadhyay for spending their valuable time and being panel members here. And on behalf of everybody from the organizers and as well as the participants, we are genuinely grateful for your time.
Thank you, sir. Now I invite Joydeep sir.
Thank you, Andrew. Once again, a very warm good evening to all the doctors, and we thank each and every doctor who has participated in this webinar once again. And doctor, we are honored that you are sharing our platform beyond boundaries to enhance knowledge. And as promised, we will be with you always whenever that is required. So thank you very much. Stay safe and good night, sir.
Thank you, thank you. Thank you. Good night, everybody.
Sir, thank you very much. Today I am in the back taking part of this because there is a lot of disturbance on network. So that is why I have to sit with a lot of things. Thank you very much, sir.